Okay, and now this next talk is supported by an educational grant from Santa Fe, and as I told you, it's looking at fixed ratio GLP-1 RAs with basal insulin, and Dr. Wysham is there. I think besides, she is a clinical professor at the University of Washington in Seattle. She's an endocrinologist. She's been very active in the ADA, chairing some of the committees. But one of the most impressive things to me was 25 years of clinical research. And she's been one of the principal investigators in the Accord, the EMPA-REG, the Canvas, ADOPT. So she's really, I think, been right on the front line of many of that. And we'll look forward to hearing her. Let's welcome Dr. Wysham.
Thank you. Well, thank you for that kind introduction. I'd like to say after 30 years in diabetes, virtually everything that I do in diabetes wasn't invented when I started practicing diabetes. So these are my disclosures. Through my research, I have been involved in advising and speaking for the companies. So we're going to really explore this combination therapy, talk about some of the strategies to reduce treatment barriers in patients with diabetes, especially related to oral agents and insulin, to describe the glucose-lowering effects of both short and long-acting GLP-1s to understand they are very different, to assess the current evidence and look at these fixed-dose ratios where we have GLP-1s and insulin in the same pen so that it's a single injection for the patients. So I think this is data that you've seen in some way or another many times before. And if we really look at the glycemic control across the United States, as of the latest NHANES database, 53% were considered under control, or that is an A1C less than 7%. That 25% had A1Cs between 7 and 7.9, and 22% had A1Cs greater than 8%. Now, many of us can argue about what an appropriate A1C target should be for our patients, particularly our elderly patients with established complications. But almost everyone would agree, unless you have a nursing home patient, that their target A1C should be less than 8%. So there's still a significant gap in terms of the control in the United States. So I'd like to start with a case, and this is a case of a woman, Jill. She's 58-year-old, African-American, 8 years of type 2 diabetes. She's coming in for follow-up on max-dose metformin, glipizide 10 BID. About 2 years ago, she started on glargine. At that time, her A1C was 7.8, and she has titrated it over that 2 years up to 40 units. She says she has a healthy diet, but overwhelmed with her job. She doesn't exercise regularly. She's had a 5-pound weight gain and has a history of frequent vaginal yeast infections. She's on appropriate medications, atorvastatin, antihypertensive meds, and aspirin. So on physical exam, she's obese. Blood pressure is 138/87. Rest of her exam is normal. So you order labs and arrange to see her back in 2 weeks. So what would you set as a target A1C for Jill? Would you select less than 6, less than 6.5, less than 7, less than 7.5, or less than 8? Please make your selection. Answers for this, so the majority of people said less than 7. I think that's a reasonable answer. You know, again, a lot of it depends on your definition of what a young patient is. So I certainly would say if she was 38, you could definitely say a lower A1C would be appropriate. On the other hand, if she was 78, you might choose less than 7.5 or less than 8. So I think the key is this patient is relatively young, and therefore we should be trying to achieve as good a glycemic control as possible. So as we move on, I'm a little trigger happy apparently. So we do have established guidelines by the ADA of less than 7% with a fasting glucose of between 80 and 130 and a peak postprandial glucose of less than 180. But the key is the asterisk, that goals should be individualized. And one of the features that is prominent in the American Diabetes Association Standards of Care is this figure that really helps you determine whether or not you want an A1C of less than 7 or whether you want it more stringent to the left or less stringent to the right. And you can see one of the major features is what happens in terms of the risk of hypoglycemia, risk of adverse events from the medications, and really importantly, disease duration. The longer duration type 2s are going to be harder to control, more hypoglycemia. Life expectancy, I like to tell my patients tight glycemic control is a 10-year investment, and therefore if they only have 3 to 4 years of expected life expectancy, tight control doesn't make as much sense. And then any established vascular complication, whether it be microvascular or macrovascular complications, do predict increased risk of having adverse events in terms of hypoglycemia and even death. And then the very last, remember, some patients just don't have the support, and we need to be really very realistic and set realistic goals for them. All right, so she comes back in 2 weeks. Her fasting glucose is 120. Her A1C is 8%. Very important message. That tells me she does not have any more room to titrate basal insulin. She's already at a fasting glucose target. Her A1C is far above target range. Therefore, we really don't have a lot of room to keep titrating. Her glucose level, our cholesterol level, you can see is a little higher than target. She has low GFR. She has elevated liver function tests. Her urine microalbumin to creatinine ratio is normal. She is quite surprised because she's been doing blood sugars in the morning and they've all been looking pretty good. So she was surprised her A1C was so high. She really wants to get it down. She'd like to exercise more, but in realistic terms, she knows that that's unlikely going to happen. So what would you recommend to help Jill improve her glycemic control? Would you give her 3 more months of diet and exercise? Would you add a TZD, a DPP-4 inhibitor, an SGLT2 inhibitor, a GLP-1 receptor agonist, or is it time to add pre-meal insulin? Go ahead. Okay, so the majority selected a GLP-1 receptor agonist. I think the only wrong, well, there's 2 wrong answers. One is 3 more months of diet and exercise. Patient already told you she's doing as well as she can. 4, an SGLT2 inhibitor is not indicated because she has a history of vaginal yeast infections and her GFR is below 45. But the best answer, given her frustration already with her weight, is something that's going to help her manage her weight, and a GLP-1 receptor agonist would be the appropriate one. All right, so you're all familiar with the AD8 position statement for treatment of hyperglycemia. This really starts with after metformin, what would you consider as dual therapy, and you can see there are 6 options. I personally really like this particular algorithm because it allows us to personalize our therapy. Every single patient walks in my office may have the same diagnosis, but they are not the same person. They don't have the same values. They don't have the same lab tests. They don't have the same underlying comorbidities. So I like to have the option to go across that second line and determine with the patient what we think is going to be the best therapy. Obviously, as a third line, we can add pretty much anything from the second line on top of the third line, remembering, but there's no indication for the addition of a DPP-4 inhibitor and a GLP-1 receptor agonist together. 0 indication, so it should not be done. And then once a patient's on 2 or 3 non-insulin therapies, it's appropriate to start basal insulin anywhere along the line, but it's once they're on basal insulin that we need to think about adding additional therapy, and the ADA suggests that we can either add prandial therapy, we can add premixed insulin, or we can add a basal, or we can add a GLP-1 receptor agonist. So you're very well aware of how these non-insulin diabetes drugs work. Specifically for the GLP-1 receptor agonists, they have an impact on appetite. They have an impact to reduce weight, which if the patient loses weight, that improves insulin sensitivity. They decrease the rate of glucose absorption, particularly the shorter acting ones. They improve insulin secretion, they suppress abnormal glucagon production, and they all work together to decrease hepatic glucose production. If you look at what insulin does, insulin has its primarily effect to replace insulin, which has an impact on hepatic glucose production and also helps to get the glucose out of the bloodstream into the tissues. These 2 compounds have very complementary actions. You can see that they really help to address most of the defects we understand that cause hyperglycemia. Remembering that, especially when it comes to injectable therapies, there's a big issue associated with clinical inertia. And I know my office is set up to train patients how to inject. It's easy for me to do. I know the majority of you in primary care don't have those systems set up, but they can be set up if you have the training that you can do with your medical assistants and have a starter kit available. But remember, insulin is what's missing. Replacing it reduces risk for complications. It does not increase risk for complications. You have to address your clinical inertia as well as the patient's inertia in order to get these medications started. So remember that in clinical studies, injectable therapies in 2 separate studies were associated with better patient satisfaction than adding oral medications. So in one case, liraglutide, in the other case was insulin glargine. So once you get the patients over the hump, you get over the hump and get the patients on insulin, it is not a big issue. And I often tell my patients, you can start in a month, come back. If you don't like it, if you don't like how you feel, you don't want to continue, we'll talk about the other options at this point. So again, make sure that we get our patients to goal, set the appropriate goal, understand their comorbidities and their preferences, make sure that you address diet and exercise at every visit, and you should assess glycemic control every 3 months and intensify if A1C is not achieved. Okay, so we're going to be moving on to first injectable. So I bet if I ask a raise of hands, the first injectable therapy in most of your offices is going to be basal insulin. But there is data that have been done with all the GLP-1 receptor agonists. And in all cases, the GLP-1 receptor agonist lowered A1C at least as well as basal insulin when it was titrated, if not better. Think about that. Think about how hard it is to get our patients to titrate. These are clinical trials where the coordinators were titrating the insulin with the patient. That is very difficult to do in a lot of our cases, whereas the GLP-1 receptor agonists have very little need for titrate, especially some of the once-weekly forms. So better A1C reduction, easier for patients to use, generally well-tolerated, and therefore should be considered as the first injectable therapy. And remember, basal insulin, all it does is bring down the background. It doesn't do a thing for postprandial glucose control. And that's where the GLP-1 receptor agonists can be helpful for your patient, because they not only bring down fasting glucose in terms of the longer-acting ones, but they also help to limit the postprandial excursions that happen after the meals. And also remember that in clinical trials, even in clinical trials, 40 to 50% of patients do not reach their A1C target. And if they can't do it in a clinical trial, it is going to be really hard for us to get the majority of our patients' A1Cs to goal in clinical practice. So once again, just to review, we do lifestyle, we do oral meds, we start basal insulin, and then it's time to move on. What do? We can do GLP-1 receptor agonists, or we can add prandial insulin or add premixed insulin. Here's one of my major take-home messages, is that this is when you know you have enough basal insulin. If its dose is more than 0.5 units per kilogram, or the weight in pounds divided by 4, you're probably at the maximum part of the dose response curve. If the fasting glucose is less than 130 and the A1C is still above 7, really no sense. You're only going to cause more hypoglycemia, and you're not going to get any better glucose control. And if the patient's reporting nocturnal hypoglycemia, by definition, that's too much basal insulin. Okay, so let's get back to Jill. So remember, she's overweight, her A1C is 8%, she's got poor renal function, her liver function tests are up. So which clinical characteristics might influence your choice of medication for Jill? Efficacy, weight, renal function, liver function, cost, or a combination of efficacy, weight, and renal function, or efficacy, liver function, and cost. So most of the people chose what I thought was the best answer, and that was 76% chose 1, 2, and 3. We want efficacy. Our patient Jill wants her weight, and obviously renal function is going to determine which medications are going to be effective or safe for her. But she does have elevated liver function tests, which we know are most likely fatty liver. Something that helps her lose weight will also help improve her liver function. Okay, so we know about the profiles of anti-diabetic medications. This actually comes from ACE, and I think it's a really nice summary of, if you're looking at your patient's comorbidities, what medications would you want to use or not use? Dr. Peters talked about the cardiovascular benefits of SGLT2 inhibitors, and we now know that liraglutide is also associated with improvement in cardiovascular outcomes. We know that particularly for CHF, that's really where the SGLT2 inhibitors shine. We know that there's increased risk of fractures with some of the SGLT2 inhibitors, as well as the TZDs, so you have to be very cautious about using those agents in people with known osteoporosis. The GU renal issues, just dose adjustment, risk of hypoglycemia with some of the medications. So again, I think this is important to just be aware that medications have different indications and contraindications. So let's move on to the GLP-1 receptor agonist for just a brief time before we talk about the combinations. So in the clinical trials, A1C reductions with GLP-1 receptor agonists range between 0.8 and up to as much as 2%. We usually say the average is 1.5% for the long-acting, probably more like 0.8% for the short-acting. They work through multiple mechanisms of action, which we just reviewed. The glucagon release is important because none of the other medications that we commonly use really impact that defect. It decreases food intake, slows gastric emptying, and increases insulin secretion. They have the advantages: they don't cause hypoglycemia unless they're added on top of sulfonylurea or insulin. They're associated with weight reduction in about 75% of patients. There is some reduction in CV risk factors, and there is a decrease in postprandial glucose. The disadvantages are GI side effects, including nausea, vomiting, and diarrhea that can generally be managed, generally are short-term, and generally tend to dissipate over time. The injection is an issue in your mind more than the patient's mind. And certainly if you show them the smaller needles associated with, say, liraglutide or exenatide BID, most patients can't even see the needles, much less be worried about it's going to hurt. And then there is a mild increase in heart rate that the cardiologists, for some reason, are concerned about. So if you look at the benefits of GLP-1 receptor agonists, this is a study that was done with IV GLP-1, and it showed that about a third of the glucose lowering for postprandial was due to the gastric emptying, about a third was due to stimulation of insulin, and about a third was due to decrease in glucagon. So all three of those mechanisms are involved in lowering glucose. Well, what I will tell you is that if you look at the differences between the short-acting, now these are two agents that are on the market now, exenatide BID and lixisenatide, versus the longer-acting, which I do include liraglutide in that because it does have a constant GLP-1 level in the bloodstream for 24 hours, you can see that there are differences, obviously, in their half-life and their time to maximum action. But also, very importantly, the short-acting agents really do a dramatic effect on the postprandial glucose excursion. Much, much better than the longer-acting. So if you have an Asian patient, if you have a patient who eats very high carbohydrate meals, they are really going to do much better on a short-acting where they won't have as much peak in their blood sugars after they eat. The majority of our patients with A1Cs that are 8% or greater, they're probably going to do fine on the longer acting, just recognizing they'll still need to watch their carbs a little more carefully. And this just shows you the difference between the postprandial effect between liraglutide, which is the yellow triangles, versus lixisenatide, which is the dark ovals. You can see when they started before the injection, they had similar increases in their glucose from up to 90 milligrams per deciliter higher blood sugar after meals. When you gave liraglutide, it lowered it down to about 60, but when you gave them lixisenatide, there was no increase in the postprandial glucose, and that is predominantly because of a stronger impact on the gastric emptying. And again, this just shows you the difference in the percentage of patients who were at target normal blood sugar after their meals, 69% with lixisenatide, 29% with liraglutide. So again, talked about this before, basal insulin, GLP-1, they're, I like to say, a match made in heaven. They really do help to meet most of the goals of the patients and address the defects that cause hyperglycemia. Okay, so Jill comes in 3 months later. At your last visit, you talked to her. She started liraglutide, 6.6 milligrams, titrated up to 1.8. She came in for her labs before her appointment. She described some mild nausea, but it went away over time. Her weight came down. She's now 199 pounds. Blood pressure improved. Her lab showed an A1C of 6.8% with stable renal function, and now her liver tests have normalized. So these are data that really show you why adding the GLP-1 receptor agonists are so beneficial. So this is a study where they took patients poorly controlled on basal insulin. They either continued to titrate the basal insulin, which is the orange bar, or they added exenatide twice daily, which is the green line. And what you can see is the A1C reduction came down with both, but there was additional 0.7% reduction in A1C with the exenatide compared to continuing to titrate the basal insulin. Hypoglycemia was similar, but remember, if you have a lower A1C and similar hypoglycemia, that's still a win because you're able to improve the glucose levels. The change in weight was not surprising. It went up with placebo. Ongoing titration of glargine, it went down with exenatide BID for a net difference of 2.8 kilograms in that 30-week trial. And again, similar to what we talked about before, this is a short-acting agent. If you look at the glucose profiles before at the top versus after, the green line is the insulin glargine. All you did was lower the baseline down. The excursions of the blood sugars, how far they came from baseline up, were not changed. But those that were on the exenatide, they had similar fasting glucose, but you can see the meals that this medication was given, breakfast and supper, they had very, very significant reductions in their postprandial glucose levels. Now, we have at least 2 studies, if not more, where they've studied adding a GLP-1 receptor agonist on top of basal insulin and comparing it to 3 times a day Lispro insulin. These are 2 different studies. The one on the left, exenatide BID on top of basal insulin versus Lispro, you can see A1C reduction was identical. The one on the right is albiglutide versus Lispro. A1C was actually slightly better with albiglutide. Weight change, not surprisingly, those on 4 injections of insulin a day put on weight. Those that were on the GLP-1 receptor agonist and basal insulin lost weight. More importantly, the risk of hypoglycemia was 50% lower with the GLP-1 receptor agonist basal insulin combination compared to adding 3 times a day prandial insulin. And 3 times a day prandial insulin is hard, let me tell you. It's hard for you, it's hard for me, it's hard for the patient. Not surprisingly, in the 4B trial, which is the one with exenatide, the exenatide was associated with nausea, vomiting, diarrhea. 17 patients, or twice as many patients, withdrew from the trial because of nausea, but still 90% of the patients remained in. All right, so let's just think about some clinical considerations. Renal impairment is important because exenatide, whether it's exenatide BID or exenatide once weekly, should not be used with a GFR less than 30. The rest of them can be used. It says to use them with caution, and that's predominantly due to the concept that it might increase GI side effects. But you can still use them all the way down to a GFR down to 15. Pancreatitis has been something that we've mentioned for a long time about these agents. No causal relationship. In the clinical trials that have been completed up to this point, those large cardiovascular trials that Dr. Peters talked about, no sign of increased risk of pancreatitis with the GLP-1 receptor agonist. But I still, if I have a patient with a history of pancreatitis, I'm a little reluctant to start it unless I have gotten to the point that I don't have any other good options for the patient. Now, I have one patient in my practice with MEN2, and I've been practicing for 30 years. That's not likely going to come up, but if you have a patient who has a history of MEN2, family history of MEN2, or history of medullary cancer of the thyroid, the longer-acting GLP-1 receptor agonists are contraindicated, not exenatide BID. Okay, so our second case is Jack, and this is actually a real case. 60-year-old man, 8-year history of type 2 diabetes, and he's coming in transferring from another practice. He's on max dose of metformin, 60 units of glargine, 20 units of insulin aspart, in addition to torvastatin and ACE inhibitor. He works as part-time at the greeter at the casino, and he was retired from the Air Force. He has fatigue, he has numbness in his feet, he's obese, his blood pressure is elevated, he has evidence of peripheral neuropathy, and his A1C is 11.9. So what do you think is going on here? Somebody says this. That's part of the issue, but not taking their meds is the other issue. Anytime you have a person on this much insulin, this many shots of insulin, and their A1C is at least in the 9s, they're not taking all their shots. You can just say double-digit A1C, they're not taking all their shots. No matter what they tell you, they're not taking all their shots. I call the pharmacy and I get their refill records and prove that they're not taking their shots. Okay, so it's common for patients to have poor adherence in diabetes. They say 21%. I think it's probably more like 50% miss some of their meds, and they need to be, you need to be aware of that. There is a higher rate of mortality, hospitalizations, and death associated with patients who are poorly adherent with their diabetes meds, as shown in this particular study. And the difference in A1Cs was 8.1 versus 7.7. It also increases cost. This is from the VA. And average cost over the course of the years, talking about $14,000 worth of average cost for a patient who are poorly adherent versus about $10,000 for those that are better adherent. $4,000 a year increased hospital costs from poor adherence. So obviously, it's hard to do this. I take lots of meds myself, and I'm not perfect. It's hard to do it. But you need to make sure that you try to decrease the complexity of the medication, because the more meds they're taking, the more different times a day they have to take it, the less likely they're going to take it. You need to also be aware of the adverse events and select your medications accordingly. You need to make sure the patients are appropriately educated so they understand why we're adding this medicine, what the goals are, what the advantages are. Make sure that the patients can afford to take their medicines. Help them out with looking at different options for decreasing the cost of their medicines. And then obviously improving continuity of care, making sure that you have a good relationship with your patient. Okay, so Jack told me, after I carefully delved into the situation, he was missing a third of his glargine, half of his aspart doses. He stopped his metformin because it gave him, quote, headaches. He eats at the buffet 4 days a week, and he doesn't take his insulin with him when he does it. So there you go. So how are you going to better manage his medicine? Are you going to send him to a psychologist and say, would you figure out what this guy isn't doing what he's supposed to do? Send him to diabetes education. Maybe they can talk him into taking his insulin all the time. Start him on an SGLT2 inhibitor. Change his glargine lixisenatide 133 or degludec liraglutide 103.6. Or restart his metformin starting at 500 milligrams twice daily and gradually increasing. And most of them said to change under this fixed dose. And again, that is exactly what we did. But in addition, I also convinced him at a later time that he should try to restart the metformin. I used the extended release product to try to minimize what perception of side effects he was having. Okay. So moving back, so the benefits of doing the combination therapy: fewer injections, weight loss instead of weight gain, lower hypoglycemia risk, lower insulin doses, a lower postprandial glucose with adding prandial therapy, particularly if you're using the short-acting, and it better addresses all the defects of type 2 diabetes with different mechanisms of action. We do know that simplifying therapy helps adherence. I'm going to skip over the details of this simply because of time. These are the fixed dose ratios that we have. The insulin glargine with lixisenatide, it's 100 units of glargine and 33 micrograms of lixisenatide. Brand name is listed. It comes in a prefilled pen. The insulin degludec liraglutide is for every 100 units of degludec insulin, 3.6 milligrams of liraglutide, also in a prefilled pen. So this is quickly, this medication is not indicated for use after oral agents, even though it makes sense to try to do that if you're going to start an injection. But just to let you know that when you look at the A1C reduction with the combination of insulin glargine and lixisenatide compared to the separate components, you got an additional A1C reduction. In this case, there was a net A1C reduction of 1.6%. 75% of patients reached an A1C target of less than 7%. If you look at the fasting glucose levels, obviously both the glargine and the combination were very good at reducing fasting. That short-acting GLP-1 just isn't as good at fasting because it doesn't last for 24 hours. Postprandial glucose excursions, again, both the combination as well as the individual lixisenatide really knocked the socks off of the postprandial glucose excursions. And if you look at weight, again, lixisenatide alone, the patients lost 2.3 kilograms. The combination, they didn't gain the weight that they did with the glargine alone, but neither did they lose a significant amount of weight. Now, looking at where it is indicated, and that is on top of patients who are already failing basal insulin or GLP-1 receptor agonists, they looked at the combination of iglar-lixi to glargine. They continued to titrate the glargine. At the end of 30 weeks, they saw a 1.2% reduction in A1C down to 6.9%. 55% of patients, or almost double, were able to reach an A1C less than 7%. And there's this combination of getting to target without hypoglycemia. Again, about double were able to do so on the iglar-lixi compared to the glargine. Fasting glucose levels were not different. Postprandial glucose levels were better controlled with the iglar-lixi. And if you look at weight change, again, about a 1.4 kilogram difference in weight. There was a reduced risk of hypoglycemia. Moving on to insulin degludec, liraglutide, again, not who haven't tried insulin before, but you can see the combination of the medication compared to the individual components, starting with an A1C of 8.3%. You can see a 1.9% reduction in A1C with a combination, greater A1C than either of the components. 81% of patients were able to reach an A1C less than 7% at the end of the study. And what you can see is fasting glucose levels are similar to the insulin. You see postprandial glucose levels are better with the patients who are on liraglutide. And I'm sorry, I have a typo on this. I just noticed. It's liraglutide. And then weight change was better with liraglutide alone. But once again, the addition of liraglutide to the ideglira reduced the weight gain that was seen. Okay, for where it is indicated, again, on top of patients failing basal insulin, patients were switched to degludec or to ideglira. At the end of 30 weeks, you can see that there was a 1.8% reduction in A1C with ideglira compared to 0.8 with degludec alone. Again, over twice percent of patients reached A1C less than 7%. And these are really similar kind of effects that we see in terms of the change in weight. So these are what the pens look like. The important message here is that for insulin degludec, it doesn't matter what insulin they're on, how much they're on, they should probably be on less than 50 to start. But you would go back to 16 units. That's 16 units of degludec and 0.58 milligrams of liraglutide. So that's the closest you can get to the usual starting dose of liraglutide. There are two starting doses for the iglar-lixi. If the patient's on less than 30 units of basal insulin, you start at 15. If they're on 30 or more, you start them at 30. And those are the recommendations in the package insert. I think it's important that you can start them at lower levels in order to decrease the side effects, but you shouldn't start them at higher levels because you'll be starting them at a higher amount of the lixisenatide and increased likelihood of side effects. And again, starting dose, we talked 16 of the insulin degludec, 15 or 30 of the glargine, depending upon their baseline dose. The dose ranges can be increased or decreased 3 to 4 days a week, every 3 to 4 days, or once a week, depending upon the patient. And I kind of think weekly is easier than every 3 to 4 days. Who does anything every 3 to 4 days? But it's 2 units if they're above target, -2 if they're below target. Okay. So on follow-up, we started on iglar-lixi. 56 units. He reported markedly improved adherence. He experienced mild nausea for the first week and had no side effects from his metformin. His fasting glucose levels are good. His weight is down 2 pounds. His A1C is 7.2, and he agreed to increase the metformin up to maximal dose. So what's the take home? Remember, progressive beta cell function, insulin deficiency, is the actual major defect that causes hyperglycemia and type 2 diabetes. And the progressive nature of that dictates the need for combination therapy. Injectable therapies can be considered at any point, particularly basal insulin. And as compared to basal bolus insulin, the combination of a GLP-1 receptor agonist and insulin, either in separate injections or the fixed dose, is associated with an improvement in A1C that's equivalent to 3 times a day titrated prandial insulin with less hypoglycemia risk, less weight loss, and better postprandial glucose. And then the fixed dose ratios offer our patients the opportunity to intensify their basal insulin without requiring additional injections. Again, less hypoglycemia weight risk and less weight gain. Okay, with that, I'll turn it back over to the chairman.
Well, thank you for that excellent presentation, Carol. Maybe time for one question here. You really didn't talk about this, but I thought it was an interesting question. Comment on the progression of diabetes using an SGLT2 versus SGLT1, or the GLP-1 receptor agonist versus the progression of diabetes. Is there a difference? You're familiar with any research?
So I'll tell you that to me that is a fundamental question. And it's a fundamental change on how we ought to be managing diabetes. And we have patients with type 2 diabetes diagnosed in their teenage years. Their beta cell function is worse than the adults that present when they're 50 or 60. And so they will march through their meds very fast and be on basal bolus insulin therapy before you know it. I see a 30 or 40-year-old, I want to change their change in their beta cell function. So anything that unloads the beta cell helps. Basal insulin helps, SGLT2 inhibitors help, GLP-1 receptor agonists help, metformin might help, pioglitazone helps. Sulfonylureas don't help. They don't hurt the beta cells, they just don't help them. So I want to get them on basal insulin as fast as possible. The younger they are, the faster I put them on. And then I'll want them to be on either an SGLT2 inhibitor or a GLP-1 receptor agonist as quickly as possible thereafter. So I think that when I march through the majority of our patients, I am choosing GLP-1 receptor agonists or SGLT2 inhibitors after metformin. And I'll tell you, my patients prefer the pill. So if their renal function's okay, I'm going to put them on the pill first because that's what they want. And I can't say that one is better than the other.